Welcome to From the Heights, a series of conversations with authors, legislators, and thought leaders who discuss the challenges of the time, offering actionable insights that you can use today. From the Heights is sponsored by the Annie E. Casey Foundation and Kaiser Permanente. Hello, my name is Bronwyn Mayden, Assistant Dean at the University of Maryland School of Social Work and Executive Director of Promise Heights, an organization that works collaboratively with over 20 organizations and 5 schools with the mission to improve educational outcomes and to build a culture of achievement among youth and to get them to graduate from high school and be college ready. This event is being recorded and is also being live streamed to our Facebook. Your attendance and participation of this event implies your consent for recording. Participant audio will be muted for today's discussion, so please feel free to use the chat box to share any ideas, thoughts, resources, or questions. Be sure to select all panelists and attendees in the drop-down within the chat so that everyone can see your questions and comments. If you are joining us via Facebook, please post your comments, questions, and resources in the comments section. Following today's discussion, we will send all registrants a link to the recording, resources, and insights shared in today's session. If you need technical assistance viewing or hearing the audio during the event, please send a chat message to all panelists and one of our technical support staff will assist you. We will be tweeting throughout this discussion. If you would like to join us, please use the hashtags From the Heights, Black Maternal Health Week, hashtag Momnibus, and hashtag the Black Maternal Health Caucus. We're pleased to be joined by 3 guests that will discuss the Black maternal health crisis in the United States. Latéy Bradford attended the University of Maryland, Baltimore County as a Meyerhoff Scholar and earned her Bachelor of Science degree in biology. She joined the joint MD PhD program at the University of Maryland School of Medicine, where she completed her PhD in microbiology and immunology. She's a doctor at the University of Maryland Department of Family and Community Medicine, and she has recently won a prestigious award from the American Academy of Family Physicians for her program Queen's Court, a postpartum health education support group for moms and babies in the family medicine clinic. Stacy Stevens is the director of Be More for Healthy Babies, Upton Druid Heights, a program of the University of Maryland's School of Social Work's Promise Heights. She has over 26 years of experience in assisting underserved women and children to gain access to medical and mental health services throughout Baltimore and the DC metro area. Ms. Stevens is clinical social worker, and she also is an instructor at the University of Maryland School of Social Work and at Morgan State University, also at the School of Social Work, where she teaches and inspires future healthcare professionals. Stephanie Etienne is a native New Yorker whose family is from Haiti. She is a passionate advocate for reproductive justice and has spent the last 12 years working for birth equity and justice by working as a doula and a midwife. Besides her midwifery practice, she is an author, co-director, co-producer of a feature documentary, Listen to Me, about 4 Black women on the front lines of Black maternal health struggle. She is inspired by the belief that the conditions under which they enter, that children enter the world should be empowered and honored. Our moderator is Tatyana Turner, who reports on African American neighborhoods, life, and culture for the Baltimore Sun. She covered local news for the Norwood News, a community biweekly in the Bronx. She received her BA from Temple University and her MS from Columbia University's Graduate School of Journalism. Before we begin, we're honored to share a message from Congresswoman Lauren Underwood, who serves Illinois' 14th Congressional District and was first sworn into the U.S. Congress on January the 3rd, 2019. Congresswoman Underwood is the first woman, the first person of color, and the youngest to represent her community in Congress. She's also the youngest African American woman to serve in the U.S. House of Representatives. Congressman Underwood co-founded and co-chairs the Black Maternal Health Caucus, which elevates the Black maternal health crisis within Congress and advances policy solutions to improve maternal health outcomes and to end disparities. Congresswoman, we're honored to hear from you now.
Hi, everybody. I'm Lauren Underwood. I have the honor of representing Illinois' 14th Congressional District, and I'm the co-founder and co-chair of the Black Maternal Health Caucus. I'm excited to join you for Black Maternal Health Week 2021. This week is an important reminder of the urgent need for bold action to address our nation's maternal mortality crisis, which disproportionately impacts Black women and birthing people. It's also a reminder of how much change we've achieved since the first Black Maternal Health Week 3 years ago, from increased attention on the issue to legislative successes. But even with this progress, we know there's so much more work to do. It is unacceptable that the United States, the wealthiest country on earth, has the highest maternal mortality rate in the developed world. And for African American mothers, the risks are even greater. Black moms are 3 to 4 times more likely to die from pregnancy-related causes than white moms. This week, we renew our commitment to the critically important mission of saving moms' lives, ending racial and ethnic disparities, and achieving true equity and justice for all. And to address the root causes of maternal mortality, morbidity, and disparities, we need data-driven, evidence-based policies that center the voices of African American families impacted by this crisis. That's why in February, I introduced the Black Maternal Health Momnibus Act with Senator Cory Booker, Congresswoman Alma Adams, and now more than 120 House and Senate co-sponsors. The Momnibus is a suite of 12 bills that build on existing legislation to comprehensively address every driver of this crisis, including robust funding for community-based organizations, investments to address social determinants of health, and policies to grow and diversify the perinatal workforce. I first introduced this legislation in 2020 with then Senator, now Vice President Kamala Harris, and I've since expanded the package with new policies to safeguard maternal health during the COVID-19 pandemic, promote maternal vaccinations, and address the impacts of climate change on maternal and infant health outcomes. These are necessary investments that will save lives and support families. I look forward to working with my Democratic and Republican colleagues in the House and Senate and the Biden-Harris administration to get the Momnibus signed into law. Because every Black mother and birthing person deserves access to the care and support they need during pregnancy, throughout labor and delivery, and for the full year-long postpartum period and beyond. Thank you for shining a light on these issues during Black Maternal Health Week, and thank you for all the work you do and will continue to do to save lives. I'm so honored you invited me to join you for this event. I look forward to the day that we're back together again in person, but until then, take good care of yourselves.
Good afternoon, and thank you so much for having me. I'm Dr. Latéy Bradford, and it is my pleasure to be here with this esteemed panel for such an important event. We certainly thank the Congresswoman for her remarks, as well as her leadership on the Hill for such an important crisis. We're discussing Black maternity care in this country, and I'd like to spend the next few minutes framing the problem. Where are we? And how did we get here? What are the underlying causes that are contributing to this existing maternal health crisis? But then we'll finish with some hope, discussing some solutions, systems level solutions to address this crisis that we face. Although I have no financial conflicts of interest to disclose, I will say that I come to this conversation and I bring to this work a lifetime of personal experiences as a Black woman, as a mother, and as a physician scientist, in that order. And so I am deeply and personally conflicted when it comes to the crisis of Black women dying at unacceptably high rates compared to our counterparts. And I have made a commitment to never dig into these issues without first acknowledging the names and the faces and the experiences of people that we're talking about. Behind every data point is a mom, is a Black woman, and is a family left behind. And so I just wanted to take this moment in loving memory to dedicate this presentation to women like Kira Johnson, Dr. Shanice Wallace, and Dr. Shalon Irving. So let's dive into where we are. What is the problem that we're facing? Congresswoman Lauren Underwood alluded to this, but if you line up the United States against all the other high-income countries across the globe, you can see that, one, the United States is standing out for all the wrong reasons. Our maternal mortality rate is significantly higher than all of the other countries shown here. But also over the period of 1990 to 2015, you can see that we are the only country whose rate of maternal mortality is on the incline. Thankfully, more recent data from 2018 from the National Center for Health Statistics has shown that there's been some improvement in our overall maternal mortality rate, which is now down to 17.4 deaths for every 100,000 live births. But we still have a long way to go. And the reason why we're here for Black Maternal Health Week is because this crisis is disproportionately affecting Black women. If you look at the rate of death for Black women compared to the US population, and particularly compared to other white women, you can see that rates of death in Black women are 2 to 4 times greater, depending on what state you live in. So if we look at the country as a whole, using this color-coded graph where darker colors reflect higher rates of mortality, you can see that the mortality rate varies significantly by state. And unfortunately, here in Maryland, we're among the worst across the country. There is some hope, though, because the studies have shown that of these total deaths across the United States, 60% of them are preventable. That means we are not without hope. We can do something about this. Let's zoom into where we are here in Maryland. If you compare the average maternal mortality rate in the state of Maryland over the period from 2013 to 2017, you can see that we are doing a little bit better than the national average. But if you look at where we were between 2008 and 2012, we're pretty much the same. Our rate is largely unchanged over the past 10 years. And so we need to move the needle here in Maryland and across this country. And our Maternal Mortality Review Committee has estimated that 80% of these deaths in our state are preventable. If we look at the racial disparity in maternal mortality in the state of Maryland, you can follow the green line and the green triangles, which reflects the rate of death for Black women, compared to that of the red line, reflecting the death rates in white women. And you can see that the disparity is striking. Black women, the rate of mortality in Black women here in our state is 4 times as great as that for white women. But I don't want to just focus on deaths. That's the extreme end of the outcome. We also need to talk about morbidity, because Black women are also more likely to experience what we call a near miss. So these episodes of severe maternal morbidity occur for every single death, there are 70 near misses, and that's experienced to a larger degree among Black women compared to white women. And these near misses can include anything from infection to blood clot to renal failure, all of which are associated with long-term health consequences. And those consequences then accumulate and affect subsequent pregnancies, which increases a woman's risk for all future pregnancies and deliveries. So how did we get here? And why are things so bleak? Well, if you consider the disparity in maternal mortality rate in Black women in the state of Maryland compared to white women and across the country, this is the manifestation, this is the product of long-held, deeply rooted systems, laws, policies, practices that were never designed to promote Black health and Black wealth. And we call these things the social determinants of health. These social determinants of health are unfortunately fertilized by systemic racism. What do you mean, Dr. Bradford? Well, last year, our premier medical organization in this country, the American Medical Association, finally acknowledged that racism actually is one of the root causes of health disparities in this country. And just last week, our new director of the leading public health organization, the Centers for Disease Control and Prevention, Dr. Rochelle Walensky, also acknowledged that racism is a serious public health threat that affects the entire nation. And it comes down to structural barriers, those social determinants of health that have lifelong negative effects, and that disparities are severe, they're far-reaching, and completely unacceptable. So we are so grateful that this is now coming to consciousness for leaders in healthcare, but we have some work to do. Dr. Joya Career-Perry, who is one of the leading scientists and clinicians around the topic of maternal morbidity and mortality, and she's also the leader of the National Birth Equity Collaborative. She published a recent paper that showed this graphic highlighting the interconnectedness of all the social determinants of health that we typically think about, education and income, access to care, housing and safety. But what she demonstrates here is that we cannot consider those things outside of the context, the historical context in this country, which includes things like slavery and Jim Crow laws and the 13th Amendment and redlining and the GI Bill. So when we address social determinants of health, we also have to consider the context in which they exist. So now we can finally get to some solutions. We know where we are and how we got here. What are we going to do about it? I'd like to propose that we consider a systems-based approach to a systemic problem, and that's going to require all hands on deck. We need professionals across disciplines to bring together the intersectionality of biomedical, social, economic, political, and environmental factors in order to get to some solutions. And some of the key areas that I'd like to highlight today are data collection. So we need to know where we are in order to move forward. We need to focus on policy, which Congresswoman Lauren Underwood is certainly at the helm of doing so. And all of those together will influence our care models, and along with community engagement and teaching and anti-racism, I think we can move the needle here in this country. So starting with data. We can't fix what we can't see. We have to acknowledge the problem by measuring it. And there is some initiative sponsored by the CDC called Erase MM, so enhancing reviews and surveillance to eliminate maternal mortality, that is helping us to provide the much needed improvements in coordinated data collection for maternal mortality rates across the country. And North Carolina really is an exemplary model of how you can use data to drive improvements in patient care outcomes. And they've done this through their perinatal quality collaborative. And this diagram from 2018 shows that over the period of 1999 to 2013, they've been able to close their gap in maternal mortality rates. Now, 24.3 deaths per 100,000 live births is still high when you consider the national average, but at least they've been able to find a way to target the women that are most affected. The next thing is we have to consider the effects of obstetric racism. If you compare the prevalence of some of the most common pregnancy-related complications between Black and white women, the prevalence is pretty similar, but unfortunately, there's a higher case fatality rate among Black women. And why is that? Well, Black women are more likely than white women to receive care in hospitals that have lower quality of care. And then we have to, again, consider our historical context and acknowledge that implicit racial bias still does exist in 2021, which affects our patient-provider interactions and the treatment decisions that are made and how patients are heard or not heard, and the patient's confidence in their provider's recommendations, and ultimately the health outcomes. I wanted to mention at this point that this is not just a US issue, and obstetric racism really does apply in other countries. This graphic is showing us maternal death rates in the United Kingdom, and you can see the disparity in death rates for Black women in that country, which, by the way, has universal health care. So it's not just about access to care. There's something to be said about implicit racial bias and racism, just straight racism in obstetric practice. And then it's important to note that education and income are not protective factors for Black women. If you look at this graph, the darker purple bars reflecting pregnancy-related deaths for Black women, it doesn't matter how far along she's gone in her schooling. We've seen examples in even the women that I mentioned at the beginning of this talk, Dr. Shalon Irving and Dr. Shanice Wallace, who had terminal degrees and yet still were impacted by this crisis. And so we think typically about education and income as a proxy to access to care, but clearly that's not the answer either. We have to focus on real, concrete methods to improve the culture of equity in obstetric practice. And this diagram just highlights 4 recommendations that the Council on Patient Safety and Women's Healthcare issued in 2016 that really focus on the education and the training of healthcare providers to improve that culture of equity. And I wanted to mention Dr. Karen Scott, who's a principal investigator from the University of California, San Francisco, who is the PI of this patient-reported experience measure of obstetric racism scale. And the data from that shows that reported experiences of obstetric racism also occur at minority majority hospitals, so hospitals like Howard and Meharry. So there's something to be said, not just about cultural congruence between patient and provider, but it's the training that providers are receiving as they go through their medical training. And it has something to do with the white patriarchal society that really does pervade the healthcare system in which we are all trained. So the goal here is to learn and to unlearn some things that have been unhealthy in our treatment of Black women around childbirth. And the CDC has thrown their hat into this game as well and provided some funding in partnership with Merck for Mothers program to launch this Hear Her campaign, which educates women and their families, their coworkers, about some of the red flag signs that everyone should know about, to be able to speak up and empower themselves to advocate when something is just not right. So we really do have to listen to Black women. And then we need to rethink how we execute and how we provide maternity care, because more interventions is not always better when it comes to the birthing experience. Many other countries have much lower rates of cesarean section, and those countries, including Australia, the UK, Sweden, and Norway, are relying primarily on midwives to provide care for the majority of their pregnancies. In this graphic, you can see the comparison between deliveries attended by midwives in the darker blue bars and those provided by OBGYNs in the teal bar. And you can see that the US is an outlier when it comes to the use of midwifery care. We also need to empower, therefore, and increase the number of midwives in this country, as well as reduce the barriers for family physicians who are well-trained and perfectly positioned to practice obstetrics as part of our continuity of care for our patients, because data has shown that that is associated with a better birth experience and often is associated with better birth outcomes as well. We also need more representation in peripartum support services, so doulas, lactation consultants, social workers, mental health counselors, and those perinatal workers need to reflect the communities that they serve. We need to recognize that community health centers also is a strong predictor of access to care, and not all women need to come to a tertiary medical center to have a baby. And in fact, there was a recent article in the New York Times that shows women are seeking out alternative locations to have their babies because they recognize that birthing in America has been unsafe for Black women. So when we consider this rethinking the paradigm for maternity care, I just want to give a shout out to Dr. Monica McLemore, who has this quote that I love, you know, are we going to retrofit? Are we going to reform? Or are we going to reimagine this system? Are we going to just tweak some things here or there and try to stick a square peg into a round hole? Or are we just going to change how this looks altogether? And I would propose that if we can send a human being in a spacecraft to land on the moon, and if we can design a coronavirus vaccine in less than a year that's greater than 90% effective, that we can do something to reduce the rates of maternal mortality in this country. There's something to be said about following the models that are working well. And if we compare the US to other countries with very low rates of maternal mortality, those other countries have universal health care, midwifery care, postpartum home visits are a standard of care, and there's also built-in paid maternity leave. The fourth trimester is something near and dear to my heart because I think this is a huge neglected and unmet period of time where women have needs that go unrecognized and unaddressed. And so this whole 6-week postpartum visit business that has no founding in data or science, we really have to disavow ourselves of thinking about just one postpartum visit at 6 weeks and then I'll see you when you become pregnant again. Certainly as a family physician, that's not how we do things. And so I think if we consider when most deaths are occurring, we can see here in this graph that 52% of them are occurring in the postpartum period. So clearly this needs to be something that's given a lot more attention and funding to provide better services to wrap around our moms. And this is where I'll introduce the program that I've started in the University of Maryland Family Medicine Clinic that we call Queen's Court. This is a health education and peer support group for moms in our clinic. It includes weekly meetings with guest speakers, time to share tips, tricks, ideas, and really provide social support from one another. But we also introduce them to the community resources that would be of benefit to them and their families. And thankfully, we have some funding to pamper them a little bit and send them some gifts along the way. So we just finished up one cycle in March and we have another upcoming cycle in May. So super excited about this particular postpartum group that captures women up to 1 year after delivery, not just 6 weeks. So moving into policy, I just wanted to make mention of 2 bills in the Maryland legislature in 2020 and 2021 that have attempted to address where we are in this state. And the House Bill 837 is what provided funding to do some implicit bias training through the MD Mom program. This is a relatively new initiative that has also provided some funding to build out our Maryland perinatal neonatal collaborative care Quality Care Collaborative. And then more recently, we have a Senate bill this year that is up for vote to encourage Medicaid to cover services like doula services, which can provide support not just during childbirth, but beforehand during childbirth education, as well as doula services postpartum. I will just take a moment to introduce this Momnibus bill. Congresswoman Lauren Underwood already mentioned it, but this really is a landmark set of legislation, and how we all can get involved is to really press our elected leaders to throw their support behind this 100%. Write letters, show up to advocacy days, set up meetings with your local and state elected leaders, because we really need to hear your voice as maternal child health workers, public health workers, clinicians in the field. They need to know that this is important to us. The other thing is you can join this movement as an ally to organizations like Black Mamas Matter, who started this whole Black Maternal Health Week 3 years ago. You can be part of the voice that is raised to amplify this issue and to bring awareness to it. So whether it's supporting Queen's Court or Be More for Healthy Babies or the Bloom Collective or any of these other organizations, we invite you to send your money to bring awareness and highlight their work whenever you're able. And I'll just mention that I have a March of Dimes, March for Babies team that will be raising money in May. So you can look us up and show us your support this summer. And then finally, engaging in conversations just like these. You're in the right place on this virtual platform, but you can show up to town halls, you can canvass your neighborhoods, you can walk the streets and raise awareness about such an important issue, because a lot of our friends and family, unfortunately, don't even realize that the Black maternal health crisis exists. So just in summary, these are some of the key elements of our systems-based approach to addressing the Black maternal crisis. And I'll leave you with some of these take-home points, recognizing that maternal mortality rates for Black women is about 4 times higher in Black women, especially in the state of Maryland, but these deaths are largely preventable, 80% in the state of Maryland. And postpartum period is a particularly vulnerable time that we have to give more time and attention to. We know that we're here because of health inequities that are rooted in systemic racism, but we are not without hope. There are systems-based solutions that require an interdisciplinary approach, community-based approach, and anti-racism education that together we really can make a difference and move the needle. So with that, I'm just so thankful to be part of this event and to be able to share these thoughts with you. I am looking forward to the other speakers, and at this time, I will turn it over to my friend, my colleague, a mentor of mine who I work closely with, Stacy Stevens from Be More for Healthy Babies.
Good afternoon. Thank you, Dr. Bradford. Appreciate all that you've shared this afternoon. All right. And it is a pleasure to be on this powerful woman-led panel. I would like to start off this afternoon by acknowledging the past contributions of trailblazers who have spoken life and given themselves to this important proposed legislation. Every woman, every birthing person, historic granny midwives, doulas, birth attendants, physicians, Dorothy Heights, Shirley Chisholm, mothers who we lost along the way, our foremothers and fathers who stood in the gap with their medical green book and raised voices demanding that during their maternity care, they wanted to be heard, to be seen, and to be understood. I would also like to offer a quote from Angela Davis. Black women have had to develop a larger vision of our society than perhaps any other group. They have had to understand white men, understand white women, Black men, and they have had to understand themselves. When Black women win victories, it is a boost for virtually every segment of society. I acknowledge the weight of this understanding. It's stressful to Black women and our families, but in centering a larger vision based on wisdom and experience, we can transform the entire health system. And so as we enter into today's presentation, it is important that we all understand the truth that was lifted in an article in The Nation, by The Nation in 2017, that what is killing America's Black infants is not race, it's not poverty or education, it's racism. That racism is why Black infants are twice as more likely to die before their first birthday than white babies, and why Black women are 3 to 4 times more likely to have a maternal death than white counterparts. And thank you, Dr. Latéy, for mentioning earlier that many of our professional organizations agree that racism is a public health issue, it's a public health emergency, and it is a determinant of health. Health is a human right, it is a social justice issue, and racism is the constant thread that intersects all of the social determinants of health, contributing to poor infant and maternal health outcomes. It is incumbent upon us that we, as in our professions, in our disciplines, in our fields, and in our departments, that we work together to eliminate racism. So today, during this presentation, I will give an overview of Be More for Healthy Babies citywide initiative and focus mostly on Be More for Healthy Babies Upton and Druid Heights, and how this collective learning and impact work has led to a significant decline in the infant mortality rate in Baltimore City, with hopes that I will present key learnings that we understand that can lead potentially to a reduction in maternal mortality. For the past 10 years, Be More for Healthy Babies at Promise Heights has worked to ensure that every baby in the community of Upton and Druid Heights is born healthy and able to live in a thriving family. It is part of the Be More for Healthy Babies citywide initiative, which uses a collective impact model to achieve its goal of every Baltimore baby is born, no matter who she is or where he lives or how much money her family makes or the color of his skin, should have the opportunity to thrive and grow into a healthy child. The initiative is funded by Care First and the Annie E. Casey Foundation and is overseen by the Baltimore City Health Department, Family League of Baltimore, and Healthcare Access Maryland. At the inception of Be More for Healthy Babies citywide in 2009, 12 neighborhoods were identified as having higher infant mortality, and additional funding was given to 3 communities to see if high intensity community level initiatives could improve birth outcomes beyond the citywide efforts. At that point in time, Baltimore had the 4th worst infant mortality in the US. 128 babies died, 27 of those were related to sleep, and Black babies died at a rate 5 times higher than others. Upton and Druid Heights was the recipient of this additional funding, and working together, the University of Maryland School of Social Work and the School of Medicine started our programmatic efforts in 2011. At that time, the infant mortality rate was 14.3 per 1,000 live births, and Black babies were dying 2 times more than white infants. Today, Upton and Druid Heights, there are about 10,000 residents who live there. The median income is $22,225. 63% of children live below the poverty line, and life expectancy of its residents is 56.7 years of age. This slide shows the Promise Heights pipeline of existing services. Be More for Healthy Babies is the cradle portion of this pipeline of work. And in this work, we meet families where they are, in their neighborhoods, and actively engage, collaborate, and support with expectant families, families who have children ages 0 to 3, and with community partners, faith leaders, business owners, to work to improve maternal and infant health outcomes. Our team is comprised of perinatal community health workers, who we call resource moms, certified lactation counselors, social workers, and a host of moms, peer leaders, and students. We receive referrals from community partners and residents, but our strongest referral is from other mothers who have previously received services in our program. The first lesson of the afternoon that I'm offering is that a collective impact model and community-based efforts are important. They have been important in reducing the infant mortality rate, and they can assist with reducing Black maternal mortality. However, it is important to note that there was a 2-year delay for that work to start at the community level. And so we have to figure out a way to expedite the passing of the Momnibus Act so that funds can move from the federal to the state and get to the hands at the community level. And as Dr. Latéy mentioned earlier, we have been doing things at warp speed as of late. And so I'm sure we can move this legislation along and get it into the hands of the community members. In addition to that, community and local funders should start now, figuring out what their collective impact model should look like and have it reflect the essence of the comprehensive package that the Momnibus offers. And so the time to act is now. The next 4 slides that I will show are maps of Baltimore City that we use during the fetal infant mortality review, when we are reviewing a fetal or infant loss to determine what structures or factors are surrounding the expectant person that could have contributed to the loss. Be More for Healthy Babies Citywide had started this practice several years ago and added a maternal interview so that reviewers had a clearer understanding of the lived experience of and the lived environment of women who experience a loss, in hopes to have a broader perspective beyond medical information. So again, the maps of Baltimore City that you're seeing here are showing various factors that we know as social determinants of health. And if you're looking at the area that is circled in green, that represents Upton and Druid Heights. It is important to note that both Upton and Druid Heights and the greater Mondawmin community, where we have expanded our work to, is a part of the geographic region that Dr. Lawrence Brown refers to as the Black butterfly, where many of the challenges that residents face are due to generations of residential disinvestment and the cumulative impact of structural, political, economic, and social cultural disadvantage. These structures, as Dr. Latéy mentioned, are deeply embedded into everything that we do, everything that we interact and interface with. And so as you see here, the darker color reflects a higher concentration of lead to the left. And so what we know is that elevated lead levels in blood during pregnancy can not only harm babies, but they can also harm moms during and after pregnancy. And the map on the right shows food deserts, and our community is in a food desert. Accessibility to adequate nutrition is important for nourishment and sustenance of expectant people, and to address healthy blood pressure in women. Nutrition is a part of the Momnibus, lessons we'd like to offer is that we need to screen all pregnant people for lead, and we need to replace all pipes in Baltimore City because we know that it is important to improving maternal health outcomes. Lessons we also like to offer and share is that these same maps and the family interviews could be used during maternal mortality review, and they could be helpful in giving a more comprehensive and humanistic perspective of what led to mom's death. Last lesson for this slide comes from one of our moms in the program who recognized as she is navigating and trying to access food during this pandemic period, that food is everywhere. It's available everywhere. It's easier to get because she doesn't have to worry about what CSA or what region she lives in, and it's available every day. The next map reflects the historic red line map of Baltimore, the birthplace of redlining, and the results of racial residential segregation around housing. They continue to impact residents of Baltimore City and other communities across the country. On the right, you see a map of the high level of vacancies. And so what we know is that housing and health are inextricably linked to health outcomes in general, but particularly to maternal and infant health outcomes. Research shows that by walking by Blighted communities, you can have an increase in your blood pressure for residents. We also know that hypertension is the most significant driver in disparities in very low birth weight and very preterm births. Stress is associated with elevated blood pressure, the stress of not having adequate housing, safe housing, and healthy housing is one of the main stressors reported by expectant people to community health workers and home visitors. Lesson offered here is that we need to inform residents, we need to inform women, we need to inform birthing people of this information so that they do not feel defeated about the challenges they encounter in trying to control their blood pressure. This next map on the left shows shooting calls, which speaks to community violence, and we can see where Upton Druid Heights is. And to the right is the high rate of returning formerly incarcerated people. All of these factors are extremely stressful for expectant and parenting people and residents. And the lesson learned here is that we need to understand which neighborhoods our families are coming from so that we can understand when they are experiencing highly sensitive periods and stressful periods in their lives. The final map shows tree canopy in the city. And interestingly on this map, the darker area indicates the amount of tree covering. And so when we look at the community of Upton and Druid Heights, we see that there's not very much tree covering. And so what we know is that tree covering can keep communities cooler. It can eliminate air pollution, which has lead particles in it, and it can protect us from the ozone. According to Harvard University School of Public Health, ozone exposure is associated with an increased risk, and I do mean an increased risk, of preterm birth and low birth weight. And populations that are greatest risk for this exposure are women with asthma and Black mothers, and particularly those who have asthma or history of asthma or respiratory issues. The environmental exposures are exacerbated by climate change and are associated with the risk of adverse birth outcomes nationally. Studies also show that elevated heat levels in historically redlined neighborhoods in cities across the country are 13 degrees higher, 13 degrees hotter than non-redline neighborhoods due to concrete pavement and less trees. This is all associated with preterm birth. Lessons learned here, we need to plant more trees. Now on to some of our successes. We all know that the infant mortality is a key indicator of community health. This data shows the progress and successes of the citywide initiative in reducing the infant mortality rate. And this is something that we can all celebrate as Baltimoreans. All right, so as we're looking at from the program's beginning, 2009 to 2017, there has been a reduction, a 35% reduction in the infant mortality rate in Baltimore City. There has also been a 49% reduction in teen birth and a 64% reduction in the infant mortality rate as it relates to the Black-white disparity. And so that is all worthy of celebrating. But as you're looking at this screen, we're looking at Baltimore City white residents and Baltimore City Black residents, what we're seeing is that the disparity continues to persist. And so it is currently 2019, 2.8 times more. And so we still have to continue to work on eliminating that disparity. Here you're seeing a slide of infant mortality rates as we are looking in Baltimore City, Upton and Druid Heights, and the greater Mondawmin community over 5-year rolling rates. And what we're seeing is a nice decline over the infant mortality rate over time. And we are seeing in between 2013 and 2017 that for Upton and Druid Heights, that it was right around, I guess, the 5.0, no, right, a little bit above that. And so, 7.2, excuse me. And so we want to recognize the decline at that point. And now what we want to show is the 5-year rolling average for infant mortality rates in Baltimore City for Upton and Druid Heights. And this is definitely something that we all should celebrate. When looking at that rate in 2014 through 2018, I want to say pre-pandemic, okay? We are showing for infant mortality, that reduction is showing at 3.8. That infant mortality rate is 3.8 per 1,000 live births. And that's below the city, that's below the state, and it's below the target rate identified by Healthy People 2030 of 5.0. And so we need to celebrate that accomplishment of the residents and the collective work that we all have been doing over the past 10 years. But there's still more work to be done. And so I want you to look at the preterm births and also low birth weight numbers there. And in looking at those numbers, they are slow to decline. And it is my belief that as we pass this landmark legislation, the Momnibus Act, that we will be able to address many of the drivers mentioned earlier related to maternal stress. And that's what's, to me, impacting and helping us have a more difficult time in seeing a greater reduction in those areas. And so finally, I just want to talk very briefly about how we've gotten to this place of reducing the infant mortality, particularly within Upton and Druid Heights. It has been a collective work. And what we first and foremost do is that we employ perinatal community health workers who are resource moms and dads. And they provide one-on-one support via non-medical case management services to expectant persons and people. And so we meet clients where they are in the community, wherever they are, libraries, work appointments, doctor's appointments, and we help them kind of overcome any barriers that they are facing at that time. We shore them up by making important referrals for mental health services, substance use services, address food insecurity, and address housing instability. And we give them tangible resources. And this slide shows the types of spaces that we try to create in some of our perinatal groups. And this is specifically about our breastfeeding groups. And what we try to do, which was kind of mentioned earlier during Dr. Bradford's comments about what health practices need to look like, reimagining what health practices look like. We try to create spaces where our clients feel, our community members feel welcome and like they belong, definitely that they belong. And we are increasing social connections and decreasing social isolation. But we're building upon existing formal and informal networks that definitely exist in the community. We conduct strategic outreach monthly and trying to identify pregnant and parenting families. We are out giving messaging around safe sleep, breastfeeding, smoking cessation, and we are hosting a variety of perinatal groups every quarter. We probably have about 25 to 30 groups per quarter. We are addressing folks' need for information and education, and we recognize that information and education is bidirectional. And so what I want to offer here is that lessons learned here is that grassroots organizing and meeting families where they are has really helped to reduce the infant mortality rate and also sleep-related deaths. And it can also assist in reducing maternal deaths. Here we see some of our trusted community champions. We acknowledge that it's important to grow and maintain strong community partnerships. Here are the barbers in our communities and the peer leaders who support much of this work. We could not do this work alone. And so we want to encourage folks who are interested in doing this work to address maternal mortality, that you need to partner with everybody, anywhere, so that they can be a part of this heavy lift of saving Black women and their lives. And so I next want to share, I'm not going to go over this slide. This basically talks about our community engagement, more importantly, our community advisory structure. We have community achievers who are our peer leaders. We have community health workers. Peer leaders support our work around breastfeeding, and we meet also as professionals who are doing this work within the community. And as most recently, these two groups have joined together. And so here you see a picture here of our future maternal and child health workforce, including children. We have created a communal learning environment for people who are pregnant and parenting and caregiving. Our meetings are open. There is a bi-directional sharing of information. We value all wisdom, and lived experiences and stories are encouraged and honored. Here are our community assets. What we know is that the communities of Upton and Druid Heights and the Greater Mandamana area are abundant communities, filled with gifts, strengths, talents, and wisdom. And during the pandemic, we saw this most interestingly demonstrated when a group of our moms supported each other's entrepreneurial dreams. And now many of them are new business owners. And so as we come to a close, we are showing a slide of the top 3 requests from residents of what they would like to see happen, what they know is important in order to have a healthy community. And so that assures us that Black mothers are clear and they can articulate their needs and their hopes of what they are desiring for their own birth experience. We must learn to listen, fund, and support them in this effort. I think I already mentioned the importance of hypertension and how it impacts Black maternal health outcomes. We know in perinatal period of risk analysis, it's showing us that 61% of the disparities in Baltimore City are due to hypertension. All right. And so in closing, I want to say that we are still in the midst of a pandemic, but I refer to it as a triple pandemic. We are in the midst of a pandemic around COVID, racism, and climate change. And we hope that the lessons that we share today will further help to move along the work to improve maternal health outcomes. And I will end with a quote from Ella Baker: "Give light and people will find their way." And at this point, it is my pleasure to introduce Stephanie Etienne, who is a certified nurse midwife based in Baltimore, and she is our next speaker. Thank you.
Thank you so much, Stacy. It's so exciting to hear what Be More for Healthy Babies is doing in the Upton Druid Heights communities. Good afternoon, everyone. Happy Black Maternal Health Week. Thank you to Bronwyn for the invitation, and thank you to my fellow panelists. Thank you to all of you in the audience for joining us here today for this incredibly important conversation. So we have heard the gut-wrenching statistics, we have heard about the need for policy change, and we're learning about innovative programming. I would like to further ground this conversation in the reproductive justice framework. Reproductive justice, as many of you may know, is the human right to maintain personal bodily autonomy, to have children, not have children, and parent those children that we do have in safe and sustainable communities. It is a framework developed by women of color activists in the 1990s. It is inherently intersectional. And in order to achieve reproductive justice, we need to change at every level and in every sector of society. And at the core of any change we hope to achieve, there must be storytelling. We need to hear about the lived experiences of people most affected by these inequities. Storytelling is critical. Storytelling is education, it is empowerment. And as people of African descent, we come from long traditions of griots. The griots were and are the truth tellers, the historians, the poets who made sense of both the natural world and our human experiences within it. They told stories not only to entertain, but to teach and forewarn and console. When we tell our stories, we are not alone. We find our voice, and when we tell our stories, we build bridges. And when we build bridges, we create community. And we know that wherever there is community, there is power. Storytelling and story sharing are a huge part of what we do at the Bloom Collective, our maternal health space located here in Baltimore. And in the spirit of storytelling towards transformation and liberation, I would love to share with you the teaser of a documentary I am co-directing with Dr. Kanika Harris. It's called Listen to Me. Listen to Me offers a glimpse into the lives of 4 women who are also reproductive maternal health advocates. And they are facing their own personal struggles to become pregnant and have healthy pregnancies and survive the childbirth experience. You will learn a bit about each of them. Dr. Shalon Irving, a public health expert who was in fact educated in Baltimore at Johns Hopkins, who tragically died of childbirth-related complications and medical negligence. You will also meet Dr. Kanika Harris, my co-director, who suffered a catastrophic near-miss experience. And you'll meet Ebony Marcel, a midwife and birth justice advocate living in Washington, D.C., who is coming to terms with the reality that she needs fertility support if she hopes to have a baby. And the 4th woman that you will meet is Joy. She is a composite character who embodies the woman we hope to be. She is empowered, she is loved, she's supported and heard. These are just 4 of millions of stories we need to be paying attention to. Our title, Listen to Me, is clear. Listen to me means listen to and believe the voices of Black women and birthing people. So let's take a look, and after the teaser, you will hear from our moderator, Tatyana Turner. Thank you for your attention.
Rashid, this is Wanda. Shalon was rushed to the hospital tonight. She's in ICU now. She's not breathing. I don't know what to do or what's happening.
Such a beautiful memorial. What is your ritual around it?
We talk to mommy in the pictures. She knows her mommy in any picture you show her. Shalon was the type of person that did everything right with her pregnancy. Did everything the OB told her, the exercise, the food, all of that she did right. When she found herself feeling sick, she went to the doctor as she's supposed to. She told them the symptoms. She expressed them. 3, 4, 5 visits, and nothing was done.
That easily could have been me.
Blood pressure was fine. Everything looked good. Nothing to be concerned about. Went to sleep, but this headache just would not go away. There was a big gush of blood everywhere. There was so much blood that I passed out. I got to the hospital and they actually stopped me and asked me for my insurance card. A nurse came running down and she saw the blood and she saw how much pain I was in and she brushed them off. And I think she called whatever code you call that we need everybody and their mama here to help this woman, and they rushed me back.
The doctors weren't telling me how close you were to passing. They weren't telling me that.
Ooh, that kind of burned today. Day 2. I don't know, like, you don't really hear about Black women having fertility issues. I've done everything and like still wasn't able to get pregnant. I've known that we've had to do IVF, but we dragged our feet. Now that we're finally here, I think I still initially needed a second to accept it, you know? But I have a really good girlfriend. She was like, girl, Beyonce had to get help. And I don't know why that made me feel like a tiny, well, it's Beyonce, of course, it makes you feel better, but I think it just made me realize that like even really strong, self-sufficient women like need help. And so I'm gonna need help. This is the last stop. We can't afford to do multiple rounds. We can only afford to do one.
Joy is my name. I stand at the crossroads. I lay my worries at the altar. They remind me of who I am. I live inside the garden of my knowing. I remember myself. Truth is my name. Health is my birthright. Mother, grandmother, aunties, sisters, they are all with me.
I don't know if we ever stop grieving. I think that, as you know, the longing and the sadness comes up in waves.
Stephanie, thank you so much for showing us that teaser. It really drives home the idea of advocacy and the power of storytelling. Good afternoon, everyone. At this time, I want to remind everyone, if you have any questions, you could pop them into the chat, or if you're joining us on Facebook Live, you could pop them into the comments. Thank you for everyone for joining us today. And we have a few questions right now. I want to get to them all and want to dive in. Dr. Bradford, the first question is for you. And this is from one of our participants, named Adjua. The question is, why do you think Hispanic women have a lower maternal morbidity and mortality rate?
Yeah, so it's really unclear. And part of the issue, which goes back to what I mentioned about the need for data collection, is we don't have good data to make any conclusions on the issue. Certainly, Hispanic women are impacted by some of the same structural and systemic biases and racism that Black women experience, but ultimately, this is not an area that is robustly studied. There is not funding pouring into maternal health right now, and hopefully that changes because this is a hot topic that people are now interested in. But I can't give you any concrete explanations, Adjua. But thank you for being here.
Thank you so much. And our next question is from Dina. Are any midwives covered by Medicaid?
Yes. So Medicaid does cover deliveries attended by certified nurse midwives, CNMs, and I believe that's across all states. The problem is that we need more of them, right? So we need more schools of midwifery across this country, and we particularly need more Black midwives, especially if you consider where we are in the city of Baltimore and our demographic. We have very few certified nurse midwives in our hospital systems, and those that practice in community birthing centers. The barrier there is that insurance doesn't always cover deliveries in birthing centers.
And this goes into a nice segue into our next question. We have a two-part question from Tiara, and I'm going to open this question up to all of the panelists. Why are midwives not utilized or widely accepted in the United States? And the second part is, what are alternatives to accessing birth doulas?
Stephanie, you want to take that first?
Well, I think there are some long-standing historical factors as to why midwives are not more utilized in our country compared to other countries with similar economic status. And I think it's really about power, to be perfectly honest, that the way the medical profession developed, doctors and OBGYNs kind of went into the hospitals and wanted to essentially control the births. And so midwives were not brought into midwives, especially at the time where midwifery began in this country. It was all Black women, starting off as enslaved Black women, and then moving into midwives who worked in the community, the granny midwives, the grand midwives. They were all Black women. And so they had the knowledge, the skills, the community trust, the long-standing historical knowledge to support birth and other, midwives, before we moved birth into hospitals, midwives were doing all sorts of care in the family. They were not just there for births, they were there to take care of everyone in the family. And as birth moved out of the home and into the hospital, of course, control moved away from the midwives and into the doctor's hands. And that has not changed, essentially. We are in a moment where, yes, midwives, mainly certified nurse midwives, in some states will have certified midwives who are not nurses, but are midwives, are in hospitals and their services are covered by insurance, but that's not true across the board. As Latéy said, as Dr. Bradford said, we need to have more midwives, both in the hospitals, in the home, in birthing centers. We need more community midwives because research is very clear that midwifery care is community care and it is effective. It is, the midwifery model of care is about, I'm talking about storytelling. I learned about the importance of storytelling as a midwife. I learned about the importance of listening to families as a midwife because That's such a huge part of what we do, is to really get a sense for what's happening in a family, what's happening in a woman's life that could potentially impact her birth and the health of her baby. So yes, there's lots of historical factors there, but we do need more midwives, absolutely.
And we do need more midwives. We have a question here actually from Shantae. How do you become a midwife?
There are many pathways to becoming a midwife. You know, we can start at the apprenticeship model, where you can become a licensed midwife, where you could follow a midwife who's practicing in the community and learn by apprenticeship. There are several midwifery schools where you can go directly once you've completed your prerequisites, you can go directly into a midwifery program and become a midwife through that route. There is the certified nurse midwifery route, where you are trained as a nurse first, and then you obtain a master's level degree specialty in midwifery. So there are lots of different routes to becoming a midwife.
Can I also just stick in a plug, because I have a personal interest here in reminding everyone that family physicians deliver babies too. Yes. And this is also part of a community-based care model. So being a medical doctor, caring for the entire family from prenatal through the obstetric, childbirth delivery process, and then after is one of the greatest joys personally for me.
And it's such a holistic model.
I would like to interject here. Definitely. Thank you for sharing that, Dr. Bradford. Many of our moms are aware of that, and they oftentimes request, because you guys have seen a mom's, their mother. So 2-generational approach, which is why I love family medicine docs, right?
All right, Stacy, we actually have a comment and a question for you. So the comment is, congratulations on the 11% increase in breastfeeding. That is incredible. Do you have more specific information on what that data, such as exclusivity of duration or any factors contributed to the increase?
So let me share this. We really are looking at those rates around mom's initiation of breastfeeding. And so we are excited that a mom is initiating, and then many of our moms are breastfeeding into at least 3 months. The baby is 3 months old. So initiation is most reflected in that number that you're seeing. And they are exclusively breastfeeding in the hospital. So initiation is important. And so what I want to say is that we really have worked hard to make sure that we had on our team certified lactation counselors. Because what we know is that for women to have to go to the hospital, it was a huge barrier, a tremendous barrier. And so we try to make everything located in the community, easily accessible, for times for moms, when they are accessible in the evening hours. Our lactation counselors will go out to support moms, will make phone calls and things of that nature. And also, I will say this, that in our perinatal support groups and our prenatal support groups, we emphasize breastfeeding early in education. And so moms know very early the importance of breastfeeding. And so that, along with having 2 certified lactation counselors on staff, and having resources to support moms in their journey, and also having peer leaders, that to me has been the key elements in leading to that success.
Perfect. It looks like we have time for a couple of more questions. Stacy, I have a follow-up question for you, actually. What is the biggest thing you think outsiders or uninformed locals often don't know, but should, about Black maternal health in Baltimore?
Well, I mean, I think my key for showing the maps today was that oftentimes when there is a maternal loss or any loss, folks just want to point a finger somewhere. And so we don't want that to land on a mom, right? We don't want that to land on a woman, for folks to feel like, oh, what happened? What happened in the process? Did she enter in early? What were her comorbidities? What happened? And so in looking at the maps, that points to the structures of her lived environment, which are impacting and setting her up, early, before pregnancy, right? And, in childhood, earlier in the lifespan. And so to me, I wanted to make sure that we got that point today through my presentation. Thanks for that question.
Absolutely. And I think that this is a nice question to wrap up with. Again, I'm going to invite all of the panelists to hop in on this question, which is how can we ensure that Black women are being protected in all parts of the birthing continuum?
I will start by saying we have to establish that this is our priority, right? From government to healthcare to individual communities. When we identify that this is something that matters to us, then our priorities will be reflected in the policies and the practices that are demonstrated. So I think part of what we're doing here is giving voice and raising awareness to something that matters to us so that we can then go press those people in positions of power to act. And I think the systems-based model that I tried to present here includes a interdisciplinary approach that does not rely on one sector, but it really does require crosstalk and collaboration among all providers and all disciplines, because I highlighted that this is a preventable thing, guys. Like, it doesn't have to be this way. So I would say by continuing to press our elected leaders and other people in positions of leadership to make this a priority.
And to add to that, I think that was perfectly stated, Dr. Bradford. I would also just say that we continue, naming the thing that we're seeing here. Let's stop beating around the bush about things. It's not implicit bias, it's racism. Let's call it what it is, and let's deal with it. It's affecting the health and well-being of everyone, and especially Black women and the babies they hope to bring into the world. So I think a little bit of truth and honesty is going to take us a long way. And to be able to envision, like Dr. Bradford said, using our imaginations, reimagining and looking forward into the future, because this doesn't have to be the thing that we end up experiencing. We can do things differently. We know what works. We also know that we used to have much different experiences with birth. We know that there are things within our own culture, within our own history, within our own lineage that are helpful. The fact that doulas are so impactful is because they're tapping into something that we already know to be true in our culture, which is that nobody should be birthing by themselves. Nobody should be birthing without community. Nobody should be birthing without hands on them to be cared for and to be nurtured. That is a very basic thing that we can be promoting everywhere. Doula support, lactation support, education for pregnant people, and support for families.
Right, I think definitely Stephanie and Dr. Bradford answered eloquently and covered all areas. I just can't think of a better time right now for us to reimagine. And I think before the pandemic, one of the biggest barriers was that folks didn't believe that we had the political will, or that we had the will to do it. And so now we can throw all that out. We now know that we can do this, right? And so let's be about the work of doing it.
Absolutely, that's a wonderful message to end with. Dr. Bradford, Stacy, Stephanie, it's been an honor to be sitting with you all, albeit virtually. This very powerful panelists we have here. And thank you all for joining again. I am going to pass it along to Bronwyn Mayden for our closing remarks.
Thank you.
Thank you. That was really, I really enjoyed that. It was wonderful to see all of these strong Black women and all the great work that they're doing, and to really present this to you during the Black Maternal Health Week. So before I go, I want to ask you to check in on your congressperson to make sure that they are supporting that federal legislation. The last time I checked, all of the members of the Maryland delegation, except two, and I'm going to name them, Kwesi Mfume and Anthony Brown. We need you guys, if you live in their districts, to please write letters to them. I already sent my letter. Dr. Bradford sent her letter, but we need your support if you're in their district. I want you to know that I want to really thank all of our guests again. I know that all of you learned so much and enjoyed it. I have to also thank our sponsors, Kaiser Permanente and Annie E. Casey Foundation. And then I want to just thank the Institute for Innovation and Implementation, as well as the Promise Heights staff for all the work in putting this event together. And then we have an event coming up, our fourth and final event for this year. It's going to be a Everyman Theater's Pipeline. It's a show about the school to prison pipeline. We will have an actor from the show really talk with us. We will do again a Zoom webinar. We'll have more information. We're working with Everyman Theater to get all of that done. So until then, goodbye and stay well.